Hey everyone, it's Dr. Towfigh. Welcome to Hernia Talk Live. I'm your host, Dr. Shirin Towfigh, hernia and laparoscopic surgery specialist. Many of you are joining me as a Facebook Live and some are here via Zoom. But as you know, I also live in Twitter and Instagram at HerniaTalk. And this episode and all prior episodes will be available to you to share and subscribe to on my YouTube channel at HerniaTalk. And guess what? We have a fantastic new guest again, and she's on Twitter. So Dr. Courtney Collins is a hernia surgery specialist at The Ohio State University in Columbus, Ohio. You can follow her on Twitter at Dr. CoMD. That's Co for Courtney and Co for Collins, MD. And I'm so happy to see her because I actually did see her in Chicago last week, but I didn't get a chance to talk to you. Welcome.
Thank you. Exciting to
Yeah.
be here. I think it's X now. I don't think you can say Twitter
Oh,
anymore.
sorry, on X. I know I should say
Elon
sometimes
Musk
I
will come
say
after
X.
you with his
Elon's gonna come after
with
me.
his
I
electric
definitely
driverless
don't want
cars.
that.
So I'm just trying to keep you safe.
Thank you, thank you. So I fell in love with Dr. Collins because she's smart, she's witty, she's very knowledgeable. She's part of our hernia friends world.
Mhm.
Last SAGES meeting, she was one of our speakers on diversity and the kind of the hernias session on SAGES. And then this year at the American Hernia Society meeting, where we both were in Chicago last week, we also had a hernias session. Were you on that panel? You were not.
I was
The
supporting in
hernias.
the audience. There's so many good female hernia speakers now. It's hard to
I
get a
know.
slot, which is great. I love that that podium's getting so crowded, Like
Well, okay. So I'm giving grand rounds tomorrow at our one of our hospitals here, affiliated with UCLA, and one of my slides is the speakers when I went to my first AHS meeting,
Mhm.
and then the speakers now. It's definitely diverse and many more females. And maybe we can just plug their new Hernias Alliance, which is an effort to band together and gain some momentum in improving research and knowledge of hernia care, especially in females. And so I think I shared this with you guys last year. Got my little, oops, hernias pin, which many of us were probably wearing at the meeting, and lots of really great positive feedback, I thought. I thought
Yeah.
the session was very well attended and very well liked and considered one of the
Mhm.
better sessions of the meeting. What do you think?
Yeah, no, I would agree with that. And we have to give a shout out, of course, to Jenny Shao, who designed the actual pin, which I think is so cute. I don't know if you guys could see, but like it's a little loop of bowel that makes the N,
Yeah, so that the
right?
loop of bell
Yeah,
is helpful because
yeah.
it kind
It's
of demonstrates the her away from the nias,
so
and there's
cute.
a hernia.
And it's purple, so it's threatened but not dead. You know what I mean? Like so.
It's not
um,
strangulated, it's just
it's
badly
yeah,
incarcerated
it's
hernia.
it's in trouble, but it's not too far gone. And then
And the
also
pin
just
is pink, which implies
it's not
female.
pink. Yeah, exactly. Probably should do something, but and then also just kind of as a for the hernias effort, and I think this was reflected at the meeting too, is that you don't have to be a girl to be part of the hernias initiative.
No.
Like, I think it like as you mentioned, it's really just to increase sort of the conversation and just knowledge and just more we just need more information. I think just about how hernias and hernia disease sort of manifest differently in women and just to understand that so we can take
I
the
mean,
best
that's
patient.
that's
You know?
that's real, right? That's a
Hmm.
thing.
Yeah.
And I don't, yeah, the guys were wearing this as cufflinks, which I thought was kind of
Yeah.
cute.
That's what I
Yeah.
mean. You do not have to be for people out there. If you want a pin, just you can tweet at either of us. We'll get Jenny to hook you up. But like you do
Yeah,
not
you
have to
can
be a
follow
woman.
the exactly.
Yeah.
It's called Hernias Alliance with an S, Hernias
Hmm.
Alliance, and you can
Hmm.
follow them on Twitter and Instagram right now.
Hmm.
It's the early stages of it, and hopefully, as they band together to develop true research for women. You may recall those of you who follow me. Dr. Jenny Shao, who's kind of the instigator of many of this. She was a guest on
Mhm.
Hernia Talk Live. And who else is, oh, University of Michigan, we learned on this show. They are going to start a watchful waiting trial for women.
Mhm.
How cool is that?
Yeah. Yeah.
Because we don't know anything
We don't
about
know anything.
what
Yeah.
happens.
And I think that's most of the conversation right now is it's not even just like, oh, hernia care is, good, bad, and different. It's just we really don't know, like, because women are generally just underrepresented in a lot of the papers that we have about hernia disease, which
Yeah.
again isn't anyone's fault in particular. It's just that it's just the a fact. Like we just don't have as much information as we probably should in this sort of space. And again, it's not, we're not blaming anyone or mad. It's just kind of trying to bring attention so we can, do the best thing for, I don't know, 50% of our patients, at least our ventral hernia patients.
So, in keeping with our title for today's talk, hernia surgeons being controversial, I
Yeah.
want some of the audience to chime in if you think it's a good thing that we have this separate kind of arm of the hernia friends world where we're focusing specifically on women's hernias. I think it's a great thing, but there are definitely people out there that consider any type of discussion of women's issues separately is divisive, or what's the other term you used earlier? Exclusionary. I
Exclusionary.
don't know. Do
Yeah.
you guys feel that? I think it's a good thing, right? It's not like we're excluding the men.
Mhm.
It's just all studies have been focused on men. We should learn about women, and maybe this whole idea of chronic pelvic pain and women do worse with hernia repairs than men is because we're not treating them differently, even though the anatomy is different.
Yeah. I,
Don't you
I think
think
that's
so?
true. And I think a lot of it, I mean, honestly, it's like you can even sort of play to people's, selfishness. It's like, women's pelvises are very complicated, right? And
It's different.
and pelvic pain is very complicated in women. And so it's sort of like,
Yes.
wouldn't you as a hernia surgeon like to understand that better? Like I know I would, because I'll be honest with you, a lot of times you get a woman with a kind of this, complex sort of set of symptoms, and like you're just like, I don't know. You know what I mean? Like you kind of take your best guess, but it's such kind of a black box right now that I think it would make all of our lives easier, if we were able to, understand that better and guide our patients through it,
I've
because it
had a
is.
couple opportunities the past several months sitting with friends of mine, new friends of mine that are either urologists or gynecologists, and I bring up like the whole women's hernia thing,
Mhm.
and it wasn't even on their radar. So they'll see women with interstitial cystitis, urinary frequency, chronic pelvic pain, and I'll say, like that could be just from a hernia, right? And they're like,
Yeah,
I mean,
you know.
how is that? There's no hernia. I'm like, they're like, I'm like, no, but that's not the point. Hernias cause pelvic floor spasm and causes chronic pelvic pain. They can have pain with orgasm, pain with intercourse, urinary frequency, all the pelvic floor issues. And then what? I
Yeah.
have so many patients that aren't getting better. Or I'm like, yeah, but then you send them to pelvic floor physical therapy and they hate it because it's so painful because you really just have to fix their hernia.
Right.
And it's just like a light bulb.
Mhm.
And then I have to start giving this lecture that I give to my residents to them.
And then yeah, and also on the flip side, right? It's like you don't want to do, if you get some, if someone sends someone with pelvic pain to a hernia surgeon, it's the only thing they can think of,
Yeah.
and it's not what it is, it's like, and then you end up, and if you're the classic surgeon where you're a hammer and everything's a nail, like you end up doing a surgery they don't need and making it worse, so it's like, wouldn't it be great
Yeah.
to have kind of a better way of navigating that, and I think that.
Exactly today, literally the patient before this was a
Mhm.
female with sciatica and a hip disorder, and they found a hernia on her ultrasound. So they sent her to me. I'm like, I went through all the symptoms, and by the way, the injection into her back and the physical therapy for her hip made her better. And none of her some of her pain was like below the knee. I'm like, that's none of that's hernia.
Yeah, exactly.
So yes, you have a hernia. Let's make sure it's not a femoral hernia. But other than that, I'm okay with you not operating on that.
Right. So
Right?
just I think we could all use, I am a woman, right? And I think it'd be nice to have just a better algorithm, so, and, it confuses me, honestly, like you just get,
Yeah.
and so I think it would help all
Yeah.
of us to not
Yeah,
just be guessing.
one of the comments is, yes, more please. I feel so alone despite seeing a lot of doctors.
Mhm.
And why is that we don't have one of the most common operations performed by general surgery, and yet there are doctors that don't even know how to diagnose, or they don't understand the symptoms behind a hernia.
I think it's because pelvic, again, there's so much going on, right? I
Mm,
mean, and to be fair, the male pelvis is also complicated, but there's a couple systems that are just a little different. But pelvic floor sort of dysfunction pain is gotten so siloed. So you have the urologists who are very good at what they do, GYNs who are very good at what they do, and hernia surgeons who are very good at what we do. But it's kind of
yeah,
hard to get a real cross-disciplinary look at things and sort of figure out like what's going on. And so again, I think it's not really it's not so much, I mean, it is sort of a lack of knowledge, but it's just sort of a lack of diversity of knowledge. We're all just so good at
yes,
the one thing that we do. And again, we're not asking people to become an expert on, urogynecology. Like that's crazy. But like, can we at least have some kind of better
yes.
understanding of maybe when to get other specialties involved or when to just do a hernia repair and that sort of thing.
You
And I
know,
think that it's that crosstalk that's missing, I think.
we had a dinner get together on, I think, that Friday night,
Mhm.
and I was like, one of my dreams would be to have unlimited funds,
Yes.
period.
Right. Period. Period.
No,
End of
but let me
podcast.
finish.
Yeah.
But to have unlimited funds and sponsor an annual meeting
Mhm.
of just discuss female hernias and
Yeah.
all the offshoots, right? Like, so for the general surgeon, because like there is the International Pelvic Pain Society, there's the Endometriosis Summit, and a bunch of other kind of physical therapy, urogynecology meetings. But this would be for general surgeons because
Mhm.
we're almost never taught that, and it'll be directed at just those in practice, and
Mhm.
just very like dry. Here you go. This is what you need to know about hernias. This is how you examine them. This is the imaging. If you feel that they may have a urologic problem, have a urologist give that talk. If you think it's a gynecologic problem, have a gynecologist give that talk. But bring those specialists to the general surgeon. I feel like
Yeah.
we don't
Absolutely.
know enough,
Hmm.
don't you
Yeah.
think?
No, I totally agree. And like everyone should have several slides on like when to call me. You know what I mean? Like I mean, and then
Yeah,
like what are
yeah,
the buzzwords
absolutely.
and what questions to ask? Because I don't even like I have no
Yes,
idea how to suss out like like a urologist unless it's like very obvious. Like like
right.
it burns when I pee. I get that one. Like I don't know what
Yeah,
I mean? Like unless it's like I don't even know what to ask. And I think right now that's actually a really important thing to tell people when they have an unclear picture and you're kind of like, listen, like, this could be a hernia, this could not be, like I'm happy to try a repair, or do you want to go talk to someone else? And you know what I mean? I think it's
yeah,
really important to not, I think sometimes we feel like we have to act like we know all the answers, like, and sometimes
correct.
listen, like I'm not sure, and you're a safe surgical candidate. This is reasonable to try, but also if you'd like to involve some other specialties in the conversation, then I think that's reasonable, and I think
Yeah,
that I
yeah,
hope people appreciate that, and I think it does help set expectations, like I
yeah,
mean,
I totally believe that. And I feel that I've learned so much from my pain doctors, urologists, urogynecologists, physical therapists, that I would love to like have most general surgeons have that experience, but I need a fundraise for that.
the limited fund
But
is,
how cool would that be? We have like a really
yeah,
great place to have the meeting
yeah.
and have a very low bar for people to be able to come and learn, and it's one of my
Mhm.
dreams. Here's another comment. My doctor and I were convinced it was an ovarian cyst. It was a classic hernia, and our whole female reproductive systems are different. Until I found a surgeon who understood the difference between women's hernia and treatment, men's treatment, I was lost. I am so thankful for the surgeons who understand women's hernias. And she gives a shout out to Dr. Robert Martindale from OHSU
Oh, sure. Yeah.
and Vahag Nikolian. So good for him. I'll let him know he got a shout out on my show.
Oh, yeah. Let them know. In Portland, Oregon. Love it.
Yeah, here's another
Um,
comment. In my 12 years of hernia surgeries, and I've had a lot, oh, I feel like I'm a constant resource for other women who get a hernia and their doctors telling them it's no big deal. The word needs to get out that women can get hernias too. That's what's so crazy. Did you know a lot of people believe women can't get
Yes.
hernias?
Oh, you know, it's funny. I literally, and this is not like, this was this very small internal grant mechanism at Ohio State. Like, so, but we
Uh-huh.
got this kind of bonkers application, which was rejected. But like, but part of the thing now when you do any study is you have to say like what you expect, how many women versus men you're going to enroll. I can't remember what the study was. It was something, it was some hernia related, but I think it was more like education. Like, it's like
Yes.
training residents or students or something. It was very, it was not like by surgeons. It was, some, I think it was a med school thing. But they
Uh-huh.
literally wrote in their application that they weren't going to recruit women because women didn't get inguinal hernias. Like that was their understanding. And again, this was not a surgeon. Like so like this was,
Oh my God.
but it was
Well,
somebody in a medical adjacent sort of specialty. And I was like, wow. And I honestly stopped reading right there. I was like, this person doesn't understand the disease process that they're putting a thing around. But yeah, someone I don't remember who it was. I want to say it was
gynecologists. There are gynecologists that
yeah.
didn't know that women get hernias.
It's crazy. Anyone can. Remember, we get them proportionally, inguinal ones at least, proportionally less. That is certainly
Less.
true.
Yeah.
But the less is not never. You know, I mean, it's just,
Yeah.
you know,
But in the I teach at the UCLA Medical School, and I
mhm.
say, hey, by the way, when do you guys get taught about inguinal hernias? And it's during their male reproductive system
Oh, that's a great question.
course.
I'm gonna ask our med
Ask
students.
your students, let me
I'm going
know.
to. I'm going to. I have no idea when they learn that. I would assume
Yeah,
it'll come up during. I'm gonna ask them. That's a great question. I have not.
because I do their physical exam, standardized patient thing.
Mhm.
And of course, I find hernias in everyone. And these are people that have been
Right.
examined, like they do it for a living.
Mhm.
Every quarter, every semester, they show up and they have students examine them as part of their practice of how to do a good physical exam.
Mhm.
And so I'm like, one guy, he did it like 5 times. I'm like, they never told you you have a rectus diastasis and umbilical hernia? I'm like, no.
Yeah, right. No, yeah, all right. I see that a lot
Um,
when I operate for an inguinal. I always check their belly buttons, right? And I was like, oh,
yeah,
did you know you have a? I'm like, oh, and it's funny. I mean, not that it really matters. I'm like, some of them like their little hernia. They're like, no, I'll just keep it. Like, you're like, all right, it's fine.
there's a whole online fetish about belly button hernias. Did you know that?
Oh, I could
Or
just fill
belly
in the blank.
buttons.
I mean, like literally fill in the blank here. That should be our next thing. Like weirdest internet communities. People can put that in the chat.
Did you know I got a DM on Instagram? Someone was asking how they can uh make an umbilical hernia, like how they can get one.
Well, so you have an
Like
Audi instead of an
he
innie. All right.
wanted an Audi. Yeah. Like, whoa, okay.
I guess that technically violates our like do no harm thing, right? Probably can't do that. Like, like I mean, like a
I was
plastic.
like, I mean, I guess you could get silicone
Fascinating.
injection or something
I
in
guess
your
that
butt,
yeah, that's
but
true. I mean, now we're down a whole rabbit hole. Who knows?
how
Like,
crazy is that?
but no, some people are very attached to their,
Yeah.
and that's fine as long as it's not causing problems. Like
Yeah,
you
so I was teaching them how to like do hernia. I'm like, when did you guys learn? And I don't remember if it's the about hernias as the diagnosis or as a physical exam finding, but it's during the male, so they're never taught how to examine a female.
oh yeah. And I would
Crazy.
just say, like, hernia exams in general, I find overwhelming for medical students, but knowing
Yeah.
the two one's really important. I swear to God, like anyone going to into primary care should have to go through like a really intensive like hernia, like hernia exam
Yeah.
course, because I think obviously it's where a lot of them are found, right?
Yeah. Yeah.
And I have referring doctors who are very good at them, and I've referring doctors who are very bad at it. Like, so I'm like, should build this an internal medicine residency.
So for those of you who are watching, if you think that developing like a hernias alliance, which is focused on women's hernias, is too exclusionary, let us know. But if you think it's a good idea, I'd also like to know, and I'll share it with our women's group. Here's another comment. I'm an RN, registered nurse. I had a total hysterectomy for endometrial cancer and was asked uh to have an umbilical hernia repaired. Oh, and I asked to have an umbilical hernia repaired during the
Mhm.
operation, but no one could coordinate it, and the hernia is now worse.
Oh, that sucks.
I'm curious if you had your hysterectomy robotically or open.
Mhm.
Um, Also, I have 2 kidney stone surgeries. Does that also weaken the abdominal wall? Kidney stone surgeries, like actual surgery, or it was like through the cystoscope? That's the question.
Mhm.
But yeah, it's totally reasonable to have your belly button hernia repaired at the time of another elective operation, right?
Absolutely. Yeah. I
Yeah.
mean, depending on what kind of repair you're looking at,
Yeah. Yeah.
I think, and that sort of thing, but assuming it's just a little belly button one, actually, I sort of wonder, I'm like, for some of these really tight, because a lot of the times the challenge is in the coordination, right? Just like they mentioned,
Yes. Yeah.
and so, I mean, this just happened I mean, we're able to coordinate it, but it's like some lady she needs a little bit of she has a gastric cancer. She needs a partial gastrectomy, but they need someone to close her belly. And so they're looking for
Oh,
like,
yeah.
then started bleeding. So she needed to write, weird ways. They're trying to like, and it becomes this huge coordination thing. But I think, kind of your points, like no one should have to undergo 2 surgeries just because schedules don't line up. So
Yeah.
another great opportunity kind of for crosstalk is like OBGYNs do amazing stuff, right? I mean, like they do, so part of me is like, gosh, maybe we should just teach other specialties. I mean, if we're talking just throwing a stitch in a belly button, like they do way
Some of them can. I would
yeah,
say
some
some
of
of
them
them
do. So, but
can.
yeah, but it's like we should go teach people. Like I should teach people at OSU, and like if you just have a little thing, like here's how to do it. You do much harder stuff than that, so you can definitely handle it.
I mean, the gynecologic oncologists, they do a lot of really complex stuff, so they
Wild
should be
stuff,
able to fix that.
but it's
I'm
like no one's
sorry that
ever told
happened
them.
to you. Yeah,
So,
could have been
but we
prevented.
probably don't need
And
to be
she's a
so
nurse, so she probably
yeah.
knows the doctors.
It kind of
Oh,
relies
that's
on
so
us
bad.
being not as possessive of that, but again, like a little belly button thing, like I have full confidence that like
Maybe it
I
was
could
bigger and so they wanted mesh or
maybe that could
something.
be. And then
Another
that kind
comment. I excuse me. I finally convinced my plastic surgeon to refer me to a hernia repair specialist.
of,
I have two Spider-Man hernias,
oh,
one
Spider-Man.
on each side. I think they mean Spigelian, not
Oh, Spaghetti.
Spider-Man.
Oh, those are fun. Yeah, okay.
I kind of want a Spider-Man hernia. Yeah,
Yeah, I'm gonna
Spigelian.
call them that
Okay.
now. That's a much better name. I'm gonna take that.
Yeah, Spigelian hernias. One on each side. Those are in the lower abdomen, by the way.
Mhm.
But they're not groin. And a small umbilical hernia. I now have a consult with Dr. Horn at Mayo
Oh,
Clinic on October 3rd. So Dr. Charlotte Horn was one of my guests as well. Go
mhm.
back and listen to her. At that time, she was at Hershey, Pennsylvania, but she's moved and she's now the main hernia doctor at the main Mayo Clinic in Rochester,
She's
Minnesota.
phenomenal. You're
She's
in very good
phenomenal.
hands.
Yeah, you're in good
Phenomenal.
hands. They planned the
Mhm.
surgery together, so I'm very happy about that, but I'm wondering what to expect for the procedure and recovery. Yeah, Spigelian and belly button hernias. Oh, this is the same patient. This is the same patient? No, different patient. Um, yeah, I mean, she does a lot of robotic surgery. I assume
Yeah,
Spigelian hernia will be done
I would
tap, right?
assume. Yeah, usually, I would
Yeah,
assume. It kind of depends on well, at least what I do with combos with plastics is it kind of depends on what plastics is going to end up doing, right? If they're
yeah,
going to make a giant incision to take extra skin out or something like that, then sometimes we'll just do the whole thing through that and like save the time. But if
good
not,
point.
like, because at the end of the day, I do a lot of I do a lot of robotic surgery as well. Like, so
Yes.
if it saves somebody an incision, I think robotics is never wrong. If they're gonna get a giant incision anyway, then I can just use that one and that one incision. So
So here's my thought on plastic surgery combo with laparoscopic or robotic surgery. The laparoscopic or robotic surgery messes up the plastic surgery
mhm.
because you're insufflating CO2 and that can get into this fat and soft tissue.
Oh, good
So
point.
it destroys not destroys, but it affects the cosmetic outcome of what the plastic surgery can do because there's now gas in the soft tissue,
Yeah.
potentially. And they want to make sure it's very flat, very soft, very smooth contour. Let's say when they're doing a tummy tuck.
Mhm.
And if you're doing their hernia repair robotically or laparoscopically before the tummy tuck part
Mhm.
at the
Yeah.
same surgery though, then your gas can affect the cosmetic outcome of their operation. So I don't recommend it.
Mhm.
But like you said, if it's a big operation like a tummy tuck and the hernias are right there, and easier to repair, that would be to me a better option,
Mhm.
to just get it all done at the same time open as
Mhm.
opposed to robotically. Plus, robotically, you get scars in
Yeah.
areas that will not be removed during the tummy tuck. So why would you
Yeah.
want that?
No, exactly.
Right? If you're paying so much for plastic
Yeah.
surgery.
Which kind of, it's funny. This kind of segues into the other kind of thing we were going to talk about today. But I think the robot. So again, I'm a huge robotic fan.
Yeah.
I love you doing it. But I'm actually like in terms of especially my complex stuff, I'm actually about 50-50 open versus like taking plastic surgery even off the table. Because I
Huh.
think
The small
robotic,
ones.
yeah, I think robots are a great tool. But I think they're not every surgery needs to be done robotically, you know. And I think there's certainly a role still for open surgery.
Uh-huh.
I think a lot about skin, you know, a lot of times maybe they don't need plastic surgery, but I'm like, you know, like they have like a giant, you know, really ugly scar from their trauma X-lap or whatever they had, you know.
Mm.
And
Yeah.
so I'm like, well, do you want that scar revised? Like, and maybe sometimes they don't. Sometimes they're like, no, I don't care. But you know, I'm like, because again, I emphasize this a lot. I'm like, on the inside, it's the same operation. You know what I mean? It's the
Yes.
exact same. And I really am very clear on that. I'm like, on
Yes.
the inside, this is exactly the same. But like, do you have concerns about the cosmesis, the scar, all that sort of thing? Because that's something I can't really, as you can't really fix with a robot and becomes more difficult, you know, to do for the plastic surgeon. So and so if they don't like their scar, or they have a really big ugly one, or they're worried about the extra, you know, those really big hernias, you'll get a lot of
Yeah.
skin, you know, like, and they want that resected. And I'm like, well, then we'll just do it open. Again, it's the exact same operation. And then
Yeah.
you can
And
often get better cosmetic result.
and for hernias, I mean, there are pros and cons to open and laparoscopic and robotic, but there are situations where it's not that much better. It's not like malpractice to do something open, even though it
Yeah,
can be done laparoscopically or robotically. And so, you gotta see what the situation is.
exactly. And
So
I
here's
think,
the situation. Sounds like I think she's had denervation. It says
oh,
generation, but I think it means denervation from a DIEP flap surgery,
oh
DIEP,
yeah. Hmm.
So yeah, denervation. Okay, good. She's confirming that. So the denervation surgery, I don't know if you do those, but it's a horrible complication with very poor outcomes from the surgery. But when I do those, it's basically like an open side tummy tuck, like you just plicate that weakened muscle, and I put a very huge, very wide mesh that's to the ribs and to the anterior the hip and the inguinal ligament, and crosses the midline. So yeah, so it sounds like it's not as cosmetic of a procedure. It's actually to deal with the
Complication. Yeah,
complication from a
yeah.
prior operation. So yeah, that'll be interesting kind of
Mhm.
combo. But with that, for sure, all the flaps are opened up just like a tummy tuck,
Yeah,
and it would expose spigelian hernias
yeah.
and the
Sure. Right
umbilical
there.
hernia.
Right in
There
front
you
of you. Yeah, you know, like so you might as well just fix
Plus,
it.
the surgeon, I hope, is going to add mesh because it doesn't work without mesh.
Yeah, yeah.
So that'll be the mesh-based repair for these hernias.
Most likely. That's again having, you know, with obviously the caveat that we haven't seen pictures or anything, but that sounds like that sounds like very reasonable approach.
All
But
right,
yeah,
so it sounds like everyone's
yeah.
very supportive online with this
Mhm,
whole uh female bent.
good. I
I'll
hope
tell
I'm
you,
glad to hear it.
my
Like,
first job, I was the only female full-time female faculty. There was another female who was part-time a plastic surgeon in the entire department.
oh gosh.
Big department. So and we had like I would say about 25-30% female residents, and they had no one to go to. So they like sucked on to me. And I just finished residency,
Hmm.
so it was a little bit overwhelming, but I took it on, right? And my chair took me
Hmm.
aside and said, Shirin, I don't want you doing any more of these women in surgery events.
Oh gosh.
And I was so oblivious. I was like, oh, but it's so good. Like we really need it. We have all these residents that are in need, and I'm just helping them with mentorship and career guidance and advancements and so on. He said, it's a little bit divisive and exclusionary, and I don't recommend it.
Yeah.
And I said, oh, wow. For a chair to say that. And then I said,
Yeah.
wait a minute, as a white guy, I didn't say it out loud, but I did say it. Aren't you an honorary member of SBAS at the
Mhm.
Society of Black Academic
Academic surgery.
Surgeons?
Hmm.
And they have honorary members. And he's like, yeah, I don't believe in that either. It's too divisive. I
Yeah.
was like, oh shoot, wow. Okay, guess what? I never listened to him. And I eventually left the job because that's kind of how it was.
Yeah.
But
Mhm.
yeah, you definitely need it. I feel like you need it.
I think all this stuff, yeah, and again, we're entering a time when kind of anything and related to this sort of, right, like DEI, anything, even if it's patient facing, gets very triggering, I think, for
Yeah.
people. What I sort of fall back on is like, the literature shows that we don't know as much about, I mean, like, it's like you don't really, it doesn't have to be political at all. Literature kind of shows that that women are promoted less, that women are, struggle to they build their practices much slower, that they're
Yeah.
quick to lose referrals after a bad outcome, where, men keep their referral bait. It's just like we have a lot of data to sort of back up the idea that there's still some sort of cultural issues, even just looking at men versus women, which is one of the least divisive sort of, I think, um,
Hmm.
you know, uh,
Yeah, of all the
not even
topics.
getting
Yeah.
into race or LGBT, and then I get into
Yeah.
the like sensational, I'm using other people's words, not mine. Uh,
Yeah.
but, we actually do have, this isn't based in just our feelings and our feelings being hurt. Like this is actually something that we can back up, that
Yeah.
there are significant
Yeah.
differences.
So the other thing we're going to talk about, just trying to be controversial here.
Right, I know. You warmed up with us
Many of
women.
you may have read there was an article in the New York Times. It was dated, oh wow, it's almost a year.
I know, right? That's not.
October 30th, 2023. Were
Oh my.
you ever called by the reporters?
I was not.
Okay.
I know a lot of people quote it because they mostly talk to people at the Cleveland Clinic, which they say in their articles, so I'm not outing anybody.
I was called. I was
You were
called.
called? Yeah, I was
Yeah,
not.
yeah. I got
Yeah,
a couple of emails and then
Mhm,
they interviewed me on the phone. My name didn't make it through it. But the
mhm,
title, okay, it's under operating profits is like the subtitle. And the title says how a lucrative surgery took off online and disfigured patients. Most, and then there's like a little byline which says more surgeons are opting for a complicated hernia repair that they learned from videos on social media showing shoddy techniques. And I think it did actually, did it? I think it hinted on our research, which was we took the top 50 hernia repairs
mhm.
on YouTube, hernia repair videos on YouTube based on number of viewerships, and we scored them based
Oh.
on Ed Felix and Jorge Diaz's
Mhm,
scoring, like to see how many of the 9 commandments it followed for
mhm.
safe operations. And there was a good chunk of them that had a score of 0.
Oh,
Did
geez.
nothing safe. And
Yeah.
these were thousands and
Fair.
thousands of viewers. And we were saying, listen, if you want to learn online about new techniques, don't go to YouTube necessarily. You have to go to like Sages or one of those societies where they vetted the video first before it makes it online because anyone can put their video online.
Mhm,
I honestly, so I was one of the 3 surgeons that scored these videos and I was getting PTSD because some of them were so bad and
mhm,
and they had multiple videos up and it was just giving me just palpitations watching these horrible surgical techniques. But
mhm,
anyway, so this angered this New York Times article. I thought it was fine, honestly. I am okay being exposed, and it's good for
mhm.
surgeons to understand how they're viewed, right?
Mhm.
Like, I'll give you something interesting. When I was a pre-medical student, I was volunteering in the ER, and
Oh, boy.
and a mom, a mom and her kids got hit in in their minivan. It was a
Mhm,
trauma came in with like the mom and a bunch of kids, and it was a bad car accident. So
mhm,
all I heard as a pre-medical student, right? I'm in college volunteering, was they brought him in, the ER doctor's like, all right, she's paralyzed. And what they meant was they gave a paralytic through the
Yeah, just
IV so they
meds.
can
Yeah,
put the tube
they
down and
medicated
take
it.
care.
Yeah. Yeah.
I thought, oh
And
my God, this mom is now paralyzed. And it's just perception, right? If you don't know the lingo or if you use the wrong language, you have to be very careful around patients, how you talk, right? Because
Mhm.
the lingo of doctors talking to each other, our vocabulary is a little bit different. We write in our notes the patient denied this, that, and the other. We're not accusing them. It's not like a denial, like in a jury trial. Do you
Yeah.
deny you weren't there during the shooting? But it's just like, unfortunately, like some of our like medical lingos like that. So this article, I think, is one of those articles where it's showing you the patient's point of view
Mhm.
of something that doctors didn't really even think twice about.
Mhm. Yeah.
Don't you think?
Yeah. It's funny. So I did a debate about this at Sages, because obviously for hernia surgeons, this really hit a lot of people hard, because
Yeah, it really did. Angry.
people,
So
I was
many angry
really
people.
angry. Yeah, people were very upset about this article. And I think because, for a lot of people, they feel like this is their life's work, is to put up good videos and kind of
Yeah.
disseminate new techniques to places
Yeah.
where maybe it wouldn't get to
So
before.
helpful. Yeah.
And I do, there is value in that for sure, I
Yeah.
mean, and so I think that's why it hit so many people hard. Um, the article I thought was, I do, in fairness to kind of both sides of it, I do wish that the article had gotten a little more, just mentioned a little more about that, and just,
Yes.
like that there have been some positive things from disseminating, videos, certainly, because before, what, you read a book and, like, I mean, like let's not forget, like, where, like, 50 years ago, how did you learn a new technique? Like, some guy kind
Yes.
of described it to you and then you would go try it. I mean, like, this is kind of, adapting new techniques has always been difficult, so I do
Yes.
that videos for sure have conferred benefits. That being said, I do think it raised a lot of great points,
Yes.
about how do we control this,
Yes.
and so now we have videos out, and I mean, you can't stop somebody from watching them and then doing what they see, and so how do we sort of control the narrative a little better, and how do we sort of and who's responsible for it? I mean, like,
Yes.
if I post a video and then someone tries to replicate what I do and does a bad job, like, am I then somehow responsible for it, because I put that out there and led them down the perimeter? I don't know, and I think we're starting to sort of figure that out, but I think it raises a really interesting question of, like, like, how do we, just not even with just hernia surgery, but in general, like, what's the right way to disseminate new techniques, because you don't want to just only do things that you learned in residency for the, 40 years of your career. That doesn't make sense. You want your patients to have access to the best treatment offered, but, how do you disseminate that in kind of a safe way? I think, and again, across specialties, that's a whole,
I
I
mean,
think.
I've had surgeons be like, "Hey, so I'm going to do this case." Different hospitals, not even a hospital where I can go to myself and oversee them. These are like outside of my area, and they're like, "Yeah, I was just going to do like what's that you guys are doing nowadays?" He's like, "I was just going to do component separation."
Oh yeah,
Well, have
which
you
is,
done one before? He's like, "No, but it can't be that hard." And I'm like,
it
"It's
can,
you can really screw someone over if
you
you don't
really
know what you're
can.
doing." And I'm
Absolutely.
like, just refer them to me or someone else that can do it. Like, you shouldn't do it. Oh, it's
Mhm.
fine. So then I started telling them like, all the things to be afraid of, and then I freak them out a little bit. But I can see a lot of doctors, especially if they're not if they don't work in an area where there's easy access to a specialist,
Mhm.
where they'll just go online and do their due diligence, which to learn,
Mhm.
and then they get themselves into trouble. And
Mhm.
they think because they're not dealing with the heart or the brain or the spine or something like that sounds really dangerous. It's just the muscle, just the abdominal wall.
Just a hernia, right?
It's just
It's
a
just,
hernia. Yeah. Yeah.
there's a lot of, I think the just a hernia rhetoric is the thing that hurts us the most, right? Is like
Yeah.
it, because I think hernia or abdominal wall surgery in general, like, has
Yeah.
suffered from people thinking that it's just this really simple thing. And it can be, right? I mean, we're talking about like little belly button, certainly, like a little tiny belly button hernia. That is a
Yeah.
simple
We
thing.
just so the gynecologist could do it.
Yeah, they got it, but like, if a gynecologist starts doing component separation, like, I mean, So yeah, in theory, I could probably talk myself through a hysterectomy, I guess, like, but I mean, I shouldn't. Like,
I shouldn't.
like,
Yeah.
I shouldn't. Like, I mean, it is,
Yeah.
where the uterus is. I know generally how to take things out of people, but it's like, that doesn't mean that I shouldn't be like offering that to patients, like, because,
So the
um,
video has the New York Times article has a bunch of pictures of really deformed people. They've had nerve damage to their abdominal wall. And lately I've been hearing a lot from patients who've had this DIEP flap and I wonder if there are way too many plastic surgeons doing these flaps and are causing injury when maybe a specialist should be doing it. Anyway, same kind of line of thought. But I lost my train of thought.
I think it's also important to remember that in hernia surgery, especially, I mean, maybe this is true for other specialties too, but our complications tend to show up a little bit later, unless it's a bowel injury or something deep,
Yes, that's right.
but our recurrences and our issues tend to show up a long time later. And
Yes.
hernia surgery, I think especially people tend to go to another surgeon, I mean, like and so I think people are out there kind of thinking they're killing it, like they're doing these, like, and I noticed that a lot in this article. They're like, I've done all this and I've never had a problem. And you're like, well, but
Yes.
you know for sure you haven't had a problem? Because I'm not confident in that. Like I've been operating for this is my 7th year at Ohio State, and I've never
Yeah.
had a major, I don't, but I mean, like, but honestly, I probably have. They just are like, well, that Collins girl doesn't know what she's doing. So I'm going to go to, I don't actually know. Like, I don't have 100%
Yeah, I
confidence.
think you're right. That is definitely one of the issues, which is that it's not like right there when you're injuring the nerve or you're in the wrong plane or you're putting it in the mesh too tight and it's going to rip, whatever that situation is that will deform the patient. They're going to show up with a bulge and you'll be like, just swelling, go home. Then maybe it's just a fluid collection and then they won't come back to you again. And that's very true. So the pictures look horrible, right?
I
These are
know.
patients, mostly women, that are very deformed with their abdominal wall. And then on top of that, they linked this notion of patient surgeons are just learning online with financial incentive because now they're doing a more complicated operation that will pay them more than if they did a lesser operation. And so they're kind of trying to say this was financially motivated as opposed to trying to do what's best for the patient.
Yeah. I mean, it's hard, it's tough, right? Like I want to believe that isn't true. But but humans being you have to it's probably true for someone out there, I mean, like just because humans have all shades of behavior. I don't think that's true. I hope that's not true for the majority of people.
So
It's
here's my thought on that because
certainly not how I make decisions in the
they
operating.
asked me this specifically during the interview. And so the Michigan data, their state data shows there's all of a sudden, out of nowhere, there's this spike in using the specific CPT code, which is a code for surgical procedures that we use to bill. Whereas in the past decade, no one's been using it. All of a sudden, people are using this code, which implies that a very much more complicated operation is being done. And my thought was, we don't really know what operation was done, right? It's possible up until recently, people have been using like just a regular hernia repair code, and then they learned that you can get more reimbursement if you bill it a different way. And even though technically they weren't doing a full component separation, if they were doing just a little bit, they were coding it as
Mhm,
if they were because they're doing quote more work. And
mhm.
so I was like cautioning them saying, just because you're seeing a spike in codes doesn't mean those codes are representing exactly what you think is going on. A certain percentage of those patients are not getting true component separations.
I think that's a really good point. Like,
Yeah.
because I mean, there's just people can bill for anything, and describe anything. You don't know what's actually happening. I
Yeah.
think you have this kind of confluence of factors too, is like, TARS, and so the transversus abdominis release, the TARS, which are kind of the big
Posterior component
out there.
separation.
Yeah, the
Yeah.
big kind of
That's the big
Cadillac
one.
the
Yeah.
Cadillac of hernia repairs, which is kind of what this article is about, is describing,
Yeah.
you know, um, those are relatively new surgery in terms of, I mean, like in terms of
Yes.
surgical lifetime, right? It's only been in the past,
Yes.
it hasn't been that long. So of course it's going to uptick because it's relatively new, and but the billing thing also happened, and then the
Yes.
robot also happened,
Yes.
And I do think, and we actually have data to show this. You're actually people are more likely to do a TAR if you match for all hernia factors like the size and
Uh-huh.
the reference rate. They're actually
Uh-huh.
more likely to do a TAR robotically than open, or feel
Yes,
it.
that's right. That's right. Yeah.
And we have I don't know, I can speculate about the reasons for that. I think it's harder to get the sheath back together when you have your belly inflated. I think TARs are a little bit easier robotically because the visualization's so good. Like you're like, oh, it's right
Yeah,
there.
yeah, yeah.
Know, so that sort of thing. So all these, anyways, you have the kind of the TAR being invented, you have the billing changes, and you have the robot. And I think all of those kind of combine to kind of make
Yeah.
it an uptick. And then to your point, yeah, we don't really know what's being done. So I think it's hard to know sort of what to make of all of that. I do in my heart though believe that I do think there are people getting component separations inappropriately. Like, and I
Yeah,
know
for
we
sure.
see them in our offices, right?
Absolutely. Yeah.
And I guess what I'm sort of wondering is, because I have this person right now who, I mean, yeah, when I'm reading her note, it looks to me, and I don't know, like, it looks to me, she had a surgery someplace else outside Columbus.
Yes, yes.
She's driving, of course, she's like driving up from like 3 hours away, which like adds a whole layer to it. It looks to me like she essentially has a whole linea semilunaris injury on one side, like they kind of, which
Oh,
for
yeah.
the people out there means that they sort
Yeah.
of stabilized her muscle complex on one side, which probably
Yeah.
means that they're dissecting in the wrong place. Like that's what it looks like to me on her scan now. Which is a kind of a catastrophe when it's that big. It can be a catastrophic complication, right? Because her whole all the muscles on your side of your belly
Because
anchor.
the nerves are there. That's a problem. And you're
Yeah,
causing new hernias in an
right.
area where the muscles are very thin. So fixing those hernias is just a disaster.
Yeah, it's you can kind of like you're mentioning with the deep stuff, like you can
Yeah.
kind of get it a little better, but like fixing it is not.
Yeah.
She's always going to bulge on that side. She's relatively
Yeah.
young. And I read her note for the
Oh,
for the indication for it, and I'm like, this girl like didn't need this at all. Like, I
oh
mean, like this is,
no. Like a
and
five
so
centimeter.
yeah, it was not big enough. It was like mostly diastasis and like only a
Oh,
and so then I'm sort of, and this is new, so I'm still muddling. You guys can tell me I'm still muddling over it too. I'm like, do I reach out to this surgeon? And I'm like, just so you know, like this happened. I'm not
have you done that before?
I haven't, because I don't really know how to frame it. But again, kind of to the point, it's like if I'm sending people out with abdominal catastrophes, I would want to know
I
that.
would want to know. Yes.
You know what I mean? Because again,
And I would be very grateful.
you know, and so I have to figure out maybe we should do that. And if we can figure out a way to frame it as like, hey, I'm not trying to like yell at you or like, but I'm just letting you know that like this is a patient of yours and they have this complication
Yeah.
and you do whatever you want with that information. But but I think, again, if we never see our complications, I mean, how can we blame people for thinking that they're doing these operations correctly? If in their mind everyone's out just looking
I
at that.
used to do that when I first got really into doing all these complications. I talked to my mentor. He's like, you should call these people. And that's what I do. I like send them my notes or whatever. So I started calling them and or sending my opera report, but I thought I should call them. And I got so much hate.
Yeah, I'm
It
sure.
was like denial, like I don't know what I'm doing. And like they were like, no, there's nothing wrong with them. And I'm thinking, like, maybe you should, nope, that's how I've done it. It's always been, and it was just horrible. Every time I made a phone call, I was the one being blamed
Yeah.
for like misdiagnosing, overdiagnosing, whatever the situation was. And so I stopped doing it. And I feel bad every time because
Yeah.
no one learns if you don't hear about your mistakes.
That's honestly
Surgeons
probably
are
what I
supposed
would
to learn
expect.
from their
Yeah.
mistakes. Huh?
Yeah. What I would expect on it. That's the thing. Part of me is like, if I reach out to this, it is a guy, just for the record. So
Yeah.
I'm not gender, but it is a guy. Like I doubt he'll take it very well. But I mean, I don't know. Part of me is like, it's probably my job to tell him anyway. Like,
Yeah.
told him and maybe it's true. Maybe this is, maybe he's done, 5 million of these and this is because we're all human. Things go bad,
Yeah.
surgery's hard. And maybe it's true. Maybe this is the one person where this went bad for,
Yeah.
and that certainly is possible. But I don't know. But again, I think we're really lacking feedback in how good of a job we actually do in a way that like cancer surgeons, like the cancer's gone and the cancer's gone. That's it. Like, like you get the answer right there. negative margins, yes, no, it's very clear. And
Yeah.
so you can kind of control it better, but hernia stuff is just harder because it's just very hard to,
Yeah,
you
they
know,
say good for you. I mean, like if I know the person personally, the surgeon, I usually call them. But if it's totally out of the blue, I choose not to.
yeah, it's
I just don't
really,
need to be abused. Here's some more comments. I realize it is a gross generalization, but women tend to be more detailed. The assessment should be based on how the patient feels, not on preconceived bias. True.
true.
Here's another one. Trying to lose weight to have surgery for umbilical hernia that has gotten bigger and hoping to have a tummy tuck at the same time. Have you had patients that have lost weight and had the repair and not gained the weight back? And is mesh usually needed? I carry most of my weight in my stomach area as a female. Um, Sounds like it's a female who's talking. Yeah, what do you know about the weight gain and weight loss and how it affects the
I
repair,
mean,
especially if mesh is used?
but if so in terms of the mesh decision will probably be based on how big your hernia is, and not necessarily the I would guess, and it kind of depends how much weight loss we're talking. It's hard to know, right? Again, you repair someone's hernia, and if they gain weight, again, you may never see them again by the time they recur. It might, if they recur, it could
Yeah,
be later. Weight gain tends to happen slowly, so usually the repair has time to adjust. Like that being said, anytime you put a significant amount of weight on, that's always going to stress kind of any abdominal growth.
yeah.
It's always better. I mean, for
But
somebody
mesh doesn't stretch, right? So it's a
that doesn't
problem
stretch too well.
sometimes.
Yeah,
Yeah,
but it's very rare that people go and they gain, you don't usually gain 100 pounds in a month, so it's usually like
that's a
something
good point.
your body can adjust to.
Do you do bariatric surgery too? No,
Oh
yeah,
God, does
me
anybody
neither.
now with Ozempic? Like, I mean, it's just like, it's like
You know, I had a patient who said, yeah, I don't want to go to that doctor because I asked him what percentage of his work is hernias. Because I always say if you're looking for a hernia specialist, at least 50% of their work should be hernia related, right? I think I'm trying to be generous. And they said, well, I used to do a lot of bariatric surgery, but now since Ozempic, I don't, so it's mostly hernias. And the patient, this is perception again. The patient interpreted that as he's looking for work, and that's why he wants to fix my hernia surgery. And I know this surgeon, like he's definitely not anyone who would tell you to have surgery because he needs to pay his bills, you know? He's a legit doctor, but that's the way the surgeon phrased it
Mhm.
made it sound to the patient that he's just in it for the money because he can't, he doesn't have enough volume anymore of bariatrics. He has to make up for it from the hernia side.
Just go looking for hernias. I know, right? It's
I
all
know.
all about perception. They probably are looking for work though. I mean,
They
that's what
probably are.
I don't think that's why they're doing the hernia repair, to be clear, but they probably are trying
Yeah.
to
Yeah.
fill their ORs with something. Yeah, I don't know where
Yeah.
that's. I will say
Uh,
that I found, I guess this is kind of related, but like I found that those weight loss drugs are really good for my hernia patients, because you kind of get someone stalled at the to fix big hernias especially.
oh,
um,
because it's hard to lose that much
We
weight
like people
without
to be
help.
at certain, and again, it's not tiny. It's a BMI of 40, which is still pretty, it's reasonable. But yeah, you'll get people kind of
Yeah.
stuck in these, and I think it's actually, I think they've been really helpful to get people to the OR for these kind of more complex ones that you don't really want to go after until they're, kind of at a more reasonable weight. So I think I probably shouldn't tell the bariatric surgeons this, but I'm like, I think it's pretty good. I think it helps me anyway. So I think, I know it's probably hurting their bottom line, but I think it's
Oh, yeah.
getting people the care they
Yeah.
need.
So going back to the article, there's some programs, I think American Hernia Society is one, maybe SAGES, where if if you sign up for a course, right? This is not like online video. There's a mentorship program assigned to it. So you take the course and then as part of the course, you're actually also having a surgeon from that course come to your hospital to observe you doing those. Well, I think first you go to that surgeon's hospital and you observe them. Then you take the course. Then you go to your own hospital and that surgeon
Hmm.
teacher
They can watch you. Yeah,
comes
they
to
can
your
watch you.
hospital
Hmm.
and mentors you through the
Mhm.
process, because it's different when you're doing it yourself, like, oh, where did I put that again? And how is it?
Right. Yeah, exactly.
Yeah.
Patient selection and kind of that sort. Yeah, that
Yeah,
kind
they make sure you exactly it's
of.
appropriateness of surgery, who you choose, when to, and so on. And then they follow up with you. I think they follow up with you at 6 months or a year or something, right? So I think that ideally that's the right way to do these
I
things.
think if I could make this, right, if I could like make rules, I think that that is how, and again, across specialties, like when they make new cardiac stents, when they make new anything,
Yeah.
you know, I think preceptorship is because I essentially learned through preceptorship. You know, I did mostly open TARS and you know, mostly open complex stuff in
Mm-hmm.
my fellowship. I came to Ohio State, which is a robotic powerhouse, you know,
How
and
many
I learned.
robots do you have?
I don't even know. They move around, you know, like, you know, but I have like 'cause our actually no, at one campus they move, at the other campus they stay in their rooms.
Okay.
But all of my OR days at my I predominantly operate at our East campus. So I have 8 OR days a month there, and 7 of them are robot days. You know, it's just crazy. I don't
Wow.
always use it. Sometimes I'm doing open surgery with the robot looking at me, but
Sitting
like
there watching, going,
but it's there. I know, right? I feel bad about it, but I'm like, as I said, like I don't think you need the robot for every case, so I don't always use it. But she is there. Her name is Rosie. She's wonderful. Um, but you know, but so I was like, I really want to learn this stuff, and but that's exactly how I did it. I didn't just watch videos. I did. You have to go to a course, I think, to get. Oh no, that's just my robotic course. Never mind. That was just to learn the new robotic system. So that wasn't
yeah,
really. But like my partners, and I have wonderful partners, which I know not everybody, no one has partners as good as mine, but I have this, you know,
I
but
don't
some,
have any partners, so I can't disagree with
yeah.
you.
Oh, my partners are fantastic. I would not be where I was, but that's what they did. They, you know, I watched them, and then they literally like my first, you know, I don't even know how many. Like God bless them, they would just come like with their laptops and just sit there and like watch me and like point at stuff and be like, do. And then I sort of transitioned to like I would book it when I knew they were like in the building, so like I could be like, can you come and
Oh,
just
that's
watch me do like
good. Yeah,
the tricky
that's the right
part?
way to do it. Yeah,
You know what I mean? But like that was really key, I think, in getting me from because I can intellectually understand it. Like I'm a fairly intelligent person. I can watch a video and read words and understand what the words say, but like
yeah.
kind of really transitioning to doing by myself, I sort of wanted a gradual approach. And I think it was really helpful. I can't imagine doing it just from a video. I think that to me that when I read this article, I'm like, I understand that people are doing that, but it just to me sounds crazy. Like I'm like, I just would
Well,
never
can
have.
you imagine if a patient reads it, how
I
crazy it
know.
sounds?
But I think kind of getting back, it's very important. I think just for any surgery you have, like don't be afraid to ask surgeons like how many of these they do, you know, like especially for complicated. And this is not just hernia stuff, but like since we're talking about hernias, but if you have a big hernia that's going to be complicated as your 12th repair, like it's fine. And if they bristle at the question, like that's weird. You know what I mean? Like it's, you know,
Yeah.
you know, you are entitled to ask your surgeon, do you do these a lot? Like, you know, and if the answer is not something you like, then find someone you're comfortable with, you know,
Yeah.
because again, I wouldn't want to be getting a pancreatic surgery
That's
case.
the beauty of the US health system. You're free to
Right.
go wherever you want.
Whatever you want, you know, and
Yeah.
I think sometimes people feel afraid to A, ask or B, switch surgeons, you know. But you know, again, it's like if especially for these complex things, like you want someone who does those a fair amount, you know.
Mhm.
There are many surgeries I can't do, and I at least am pretty frank about like I'm like, no, I don't do that surgery. And but here's a list of 20 people who do, you know, and I
Yeah,
you know, and I think that's
agreed.
fine, but don't be afraid to ask, like, you know, like how long have you been doing this? Like, you
Yeah.
know, how many have you done? And waiting for an answer that seems reasonable
And
too,
get
you know.
second opinions. Yeah. Always get second opinion. I
Yeah.
think everyone for any surgery should get a
Well,
second opinion. I
third
had
opinion.
surgeries myself. I knew the surgeon. I trusted the surgeon, and yet I still got a second opinion just to make sure all the questions that I need to ask were
Mhm.
asked, and I was doing the right thing. It's surgery.
Absolutely. You should be
Yeah,
comfortable. It's kind of a team thing. You want to both be comfortable, you know? And
yeah,
so if
yeah,
I don't want to drag someone or trick someone into the OR, that's never a good idea. You know what I
yeah.
mean? Like, so, you know, but don't be afraid to like again with all this new stuff or any doctor, you know, like they're like, oh, I'm gonna use this new again, stent's the only word I can think of, you know, I'm gonna use this new stent. You're like, okay, cool. Like how many of those have you put in? Like, you know, like I
Right?
mean, you know, that's always a
Yeah,
fine, especially with new things. That's always a fine thing
yeah.
to ask, you know.
Well, I feel we haven't been controversial enough this hour.
Well, that's what you have to do me part two, and we'll get a we go off about optimizations. I was like, I should have done that. Like smoke.
Oh,
Should we
yes.
operate on smokers? I actually think yes, but anyway, like,
On smokers and people with a high BMI.
Yeah, I think here now if we could go to we're segueing to hour 2 now, but I think cutoffs for surgery are a bad like strict cutoffs are a bad idea. Like that's I think it's anyway, we'll talk about that next time.
Well, that's the end of our Hernia Talk Live tonight. It was fun. I've always enjoyed my time with Courtney, Dr. Collins. She's amazing, smart, funny. I like the funny part. Great person to
Yeah.
speak with. I
Mhm.
will miss you. We'll see you at the next meeting. When am I going
Well,
to see you?
absolutely. I'll see you. We'll talk again soon. So
Ages moving. Okay. All right. Thanks everyone for joining us. Don't forget, go to YouTube to watch this and all prior episodes. Subscribe and like. But also, guess what? We have a podcast. So you can actually listen to the audio as a true podcast, all 185 or so episodes. So Hernia Talk Live as a podcast. Enjoy it and go back. And I think there was one question about University of Michigan hernia specialists. There are many, and I've let's see, I have interviewed 2 of them. So go back and search for the 2 fantastic hernia specialists at University of Michigan, and I will see you all next week. See you all.
Buddy.